Hello, welcome to What the Flip podcast. I'm your host, Victor Vogel. Welcome you back to our series on healthcare cost. And we're going to be taking a look at some interesting things this evening. But there's something I'd like to cover just before we get started that kind of refers back to some of the stuff I was telling you about last time and the time before about the randomness of how healthcare isn't just a bunch of old people driving up a lot of costs, that across all of the segments of age brackets plus healthcare level, the level of your health, uh, how fit you are, how healthy you are. Across all of that area, random issues arise that generally can impact high levels of cost out of healthcare. Some of them not as sustainable as the elderly is, but nonetheless still there and still random and still costing. And one of the things that came to my attention today, I caught on an actual CBS News segment, and it involves women, and it's about mammograms and preventive health care of all things. That it really is extremely confusing and is a very good example of some of the things that I was talking about that drive the cost of healthcare up. Professional services in this case. Uh, and in some cases, these professional services are tied to being done within hospitals. So we're noticing that as we go through time, and I've noticed it as I've done research in this area. So when I get your coffee and settle in, I want to show you a brief segment of CBSN News. Give them credit for this. I'm not trying to steal their thunder, but I thought it was very interesting, and you can go get some coffee here. That's good. That gets me started on this session. So let me just share my screen here with you a minute and take you and just let you see this segment for just a minute. May take it just a segment to pop up here. Yeah, let me stop this for a second and let me try to reprogram that a second here while we're at it. Could be that I left it up there just progressing a little too long. So just give me a minute and I'll be right back to you. I'm refreshing it to see if I can pick it back up. All right. Okay. Think I've got it here. So let me go back and share my screen again for a minute. Here we go. The reason I'm taking this time is I think it's important for you to hear. It, okay. There
then
you
a
go.
screening mammogram is likely to be just fine for you. The problem is nearly half of all women basically in the group that needs mammograms, that is women over 40, who are supposed to be covered under the Affordable Care Act, under Obamacare, with a free screening mammogram every year. Guess what? The regular screening mammogram is not enough testing to diagnose breast cancer in these women because they have dense breast tissue. It's hard for a regular mammogram to see through that dense tissue. So the doctors will say, listen, because you have dense breast tissue, we need a follow-up. We need an ultrasound. We possibly need an MRI. We need these other imaging tests. So essentially, it seems to create kind of a two-tier system. If you're in the group of women that don't have dense breast tissue, you're fine. But if you're basically like the other half of women, guess what? Your screenings are not paid for. So there seems to be sort of a basic unfairness in that system.
Yeah, it's sort of a bit of a gray area, and you're right. A lot of women, a lot of my own friends, sort of automatically have to go for a second screening. They already know that they have dense breasts from all their previous mammograms that they have had, and so you think, well, why didn't you just have the more detailed screening first? Why do we have to go through this sort of less effective round of screening? It's really confusing what falls under preventative care. Can you explain how this works?
Well, basically the way it works is that under the Affordable Care Act, they provided for what is defined as a screening mammogram to be covered. But if your doctor says you might have a lump, or if you are a breast cancer survivor, oftentimes they'll say, well, your mammogram is not a screening mammogram. It's actually what they call a diagnostic mammogram. Now, you as the patient, you're going in, it might seem very much the same to you. You're getting a mammogram, right? But a diagnostic mammogram might include additional views. They might do several more views of your breast tissue in more detail, right? And the diagnostic idea is that they're supposedly looking for something, but they're really looking for something in both these mammograms. It's just a difference of how they conduct the actual mammogram itself. And here's the key. The insurance companies say, we pay for screening, but we don't pay for diagnostic. So one woman goes in, gets the mammogram, essentially the same thing pretty much. And yet there's a screening and paid for, and the other woman gets the mammogram and it's not paid for.
Anna, one last question. How does this impact patients with underlying health conditions?
Well, when you're talking about mammograms, I think that if you have an underlying health condition that relates to your mammogram, or for example, you're a breast cancer survivor, you really do need to prioritize getting in and getting those tests. It's not worth the risk to your health. What's really disturbing, however, is that every time we do a story on this, I hear from women who say, I'm not going in for the test now because I can't afford it. I'm getting, like one email a minute on this, and they're saying that they are not going to go in for the test because they can't afford it because they get these bills.
Incredible reporting there from Anna Werner, as always. Anna, thank you very much.
Okay, so what we found here is a pretty good example of what I've been saying through several of these sessions, and that is, remember we said that some of the biggest costs associated with healthcare was not necessarily pharmaceutical drug prices, although they do help people quite a bit who are particularly in the lower income brackets and don't necessarily have insurance, but also the professional services, of which is mammogram, engages two people in those professional services: the doctor who's requesting the service, and the actual people who conduct the mammogram, whether it's within the hospital facility, which a lot of testing is done within the hospital facility, which makes it more expensive per test to start with. But it's just one of those things where people get really concerned about, getting hit with this horrendous bill. And that's what's going on with these ladies that was in this particular segment of news. And that is, most people really don't understand this dynamics of screening versus diagnostic and all that. They're not technical. And it's not explained. If you go try to ask I did just before I went on the air, I asked or got online and I tried to determine if my private carrier that supplements me in Medicare actually pays for any diagnostics under Medicare for diagnostic mammograms, and they keep, every time you put this, the concept of pay for diagnostic mammograms into your search engine, you keep coming back to, oh, we pay 100% for screening once a year. That's what where they're getting hit with all this extra cost is not the screening. It is when they recommend a second test to come along. And so consequently, people are just getting hit up real hard with expenses on additional tests that are requested, etc. And it's not that they're not necessarily needed. It's just that, one, they're a surprise to people. And two, what is the definition, as you heard the news anchor say, why don't you just do this to start with and pay for that, and then you don't have to go come in and do the screening, pay for that, get billed insurance for that, even though they pay 100% of that in Medicare, for example, or even on private insurance plans, that test. Why aren't you able just to administer the test that's necessary to determine right out front one test? So this is the complication I'm talking about, where money is not coming out of necessarily the doctor. The doctor may feel this is necessary to do. It is a process of requiring double screenings, and the screenings to be done maybe within the facility of the hospital or in conjunction with people who are affiliated with the hospital organization. And one of the things you find out is that people are charged different rates. Sometimes within the same community, charge different rates. Certainly between cities or counties or states, there are different rates for these, and some of them are much more expensive than others. And that is what is compounding our healthcare cost. And by the way, remember, there was this government portion that's paid where the government pays for health care, primarily Medicare, Medicaid, those things, but some supplemental stuff for private people. But then it's that private insurance piece that drives us so much more, makes us so much more expensive than the rest of the healthcare world out there in similar countries that are, again, democratic, free enterprise systems, etc. So I also, just to maybe take a look at a couple of other things I discovered here while I was going into this, to find out how much your test, let's see, in this case, this is coming off of my website from my private insurer. To find out how much your test is going to be, item or service will cost, talk to your doctor or your health care provider. The specific amount you owe may depend on several things, okay? Other insurance. Do you have other insurance? Like, if you're paying for two insurances, you would think you'd get to use two insurances, right? But they play off against each other, and they won't let you use one if you use the other. In other words, use two insurances you're paying for to reduce the bill to nothing. How much your doctor charges you, how much your physician is charging you for this, whether your doctor accepts assignments to like Medicare, Medicaid, that kind of thing, the type of facility that you go to, whether it's a hospital or a private facility that does this. In many cases, private companies will do it for a lot less money than a hospital, because a hospital is part of a large conglomerate of people and they have to take care of those things. They have to raise their rates to cover all of the other expenses they're encompassing in there. So, and it's also where you get tests, whether, what city you're in, what state you're in, etc. And the item that you're getting tested for, or even the service that's provided you during your testing. So here is the scenario. Now, you have to start, and it's a real good point about why I am trying to get people to watch this series, because you have to understand what's going on. You have to understand what's going on. And this one, insurers often require members to pay a greater share of the cost for diagnostic scan to combat. Now, get this: if you think the government would control you, listen to this statement. Insurers, your private insurance, all of them kind of working in conjunction, so to speak. Insurers often require members to pay a greater share of the cost for diagnostic scans to combat overuse of such tests and steer patients to preventive services where possible. So they're basically assuming that you want to run up the bill that you have, that you're going to end up paying, or that if they didn't charge you a lot extra and not cover this, that you would take this and you would just abuse the heck out of these tests just so you can, feel comfortable or whatever. I mean, I don't know many people who enjoy going in and doing these things. I don't know many of them. I would get you the vast majority of the country would not do that. They would not run up and abuse an exam, especially one that is focused on potential discovery of cancer and what's going on with that area. Why would they abuse that? But that's some of the rationale that's given by the people who run the businesses, not the providers, not your doctors. He's not purposely sending you. Your doctor probably knows you well enough and has a relationship with you well enough that when my doctor recommends I go do something, I try to go do it. Okay, because, I know we're working together to make me healthier. And he wouldn't recommend something that he didn't think would help me discover all of that. And to make sure everything was safe, But even at that, I asked him, I always ask my doctor, is this necessary? I mean, do I really have to go through this? Because I don't want it. So I don't want to abuse it, but I sure don't want to do it. But we talk about it, and then I know that's something that he's thinking. Now, the fact is, he may be tied into a hospital group. In other words, he's really working in conjunction with a hospital, because that helps him where he doesn't have to pay a lot of the cost associated with these things up front, and then go through the process of billing you and going through healthcare insurances and things like that. You recognize the difference, say, between a general practitioner assigned to a hospital who's basically running diagnostic tests, and then they ship out the charging and all that kind of stuff. And all you're paying the doctor was the time for him to diagnose that. He's not trying to collect for that lab test. It's already been billed out to you via the hospital. You may not see it. It may go directly to your insurance company, but it's billed out primarily from the hospital. And for a lot of doctors, reason they do that is they're having trouble keeping their cost of doing business down. There are so many people who can't afford to pay you and look to you and just assume you're going to have grace for them and you have to pay your nurses and your building and your rent and the drug liability insurance up the wazoo. So, a private doctor today trying to be independent in the community is very much at a disadvantage to a doctor who affiliates with a hospital and makes sure everything runs through that hospital. It's kind of like you can't just call them up and say, hey, meet me in the office. I've got an emergency nowadays for most doctors. They're normally saying, hey, look, in off hours, you kind of need to go to the emergency room. That's an affiliation with a hospital. And the price is higher to go to that emergency room or to emergency care center than it normally is to go visit him. So that's part of the problem that we're running into in that process. So I just kind of wanted to bring that up because I think that's really important before we go ahead and get into question number 5 here on our series. Let me just kind of cut it off there. If you have any comments along that line, feel free to put them in the comment section, and I'll kind of pop them up like this and let people see them and at least share the comments if they're shareable. So that's part of what we can do when we're on these programs live like this. But let's talk a little bit about question number 5 in our series. Okay, so let me share my screen again with you. And here we are. On this screen here, what we're seeing is a question number 5 here, which is expenditures are high and variable for those with the poorest health. And you might be saying, duh, of course, but there's more to it than just that. And really what we're going to do is we're going to kind of take a look at this chart down here. And let me sort of explain this. On this side are annual expenses for the year 2017. I think that's like 3 years back, but these don't always happen during the year that you're trying to talk about them in these studies, but it's still a pretty reliable study. And we're going to be looking at how much people spend annually. We're going to be looking at the 10th percentile, the lowest people, and we're going to be looking at the mean, the average spending, and the highest spenders, those up in the 90th percentile of spending on healthcare. And we're going to look at them from the perspective of excellent health, very good health, fair health, and poor health, with moving from the best health that you can have to the worst health you can have, with this little deviation here. The difference between good and fair just spreads it out a little more, because there's not much difference, a little bit of difference, maybe double between here. So it kind of divides it up where you can see it a little easier when you have, 5 categories, say, then versus 4. And really, what this is saying in here is that self-reported health, people report self-health on a regular basis. When you go to the doctor, you fill out your form saying you have this, you don't have this. The vast majority of the time, for the major issues, you find that people tell the truth on these forms. They're sort of fearful not to, particularly if they have insurance, because if you lie like that, they don't necessarily have to pay the insurance, if they catch you lying about it. So most people are pretty honest on self-report forms, and they kind of coordinate with something called biomarkers, laboratory biomarkers, and these are people who actually, take a look at and report back the physical information after somebody's completed a form. And, if they go, for example, admit in a hospital, they complete a form, they run a whole bunch of diagnostics on you, and then they take those biomarkers or diagnostic biomarkers, and they compare them sometimes against the form you filled out to see how accurate we were, and they find pretty accurate for most part. So just to keep that in mind, what this is saying is people enjoying good health are unsurprisingly not a major driver of healthcare expenditures. Among those who report excellent health, though, even though at the 90th percentile of expenditures, the highest spenders of healthcare in the excellent health condition, they normally only average about $5,780 a year at the 90th percentile, and that's just slightly above the average for that group. Now, so what would drive you up in that 90th percentile? Car accident, slip and fall, like me falling and slipping and breaking my hip on ice. You could have sports scenarios. You could have unexpected cancers. And who knows, you might get involved in a pandemic. So, I'm pretty sure that 90th percentile for all levels of those categories is going to shoot up quite a bit when they go back and look at this a couple of years from now. So on the other end of the spectrum, from those healthy people, are those that are reporting poor health on an average basis, spending about $26,000 a year. And that's very expensive. So you're seeing that happening in a very expensive way. And what that normally is, are people are in fact, let's go down to the chart here and take a look. People are in fact in these bracket areas here are actually they're on a sustained healthcare problem, dialysis, diabetes, cancer, and these are ongoing, very ongoing over here in this far right column here. And even in that poor condition, there are people who only pay about $700 a year in the poor healthcare, and I was one of those people all the way up until 2 years ago when I slipped on ice and fell. I mean, I virtually was probably spending half of $700 a year on. Maybe I'd go if I thought I caught the flu, I'd go to the doctor and get some medication for it or something. But other than that, I just didn't go to the doctor. I never was in a hospital. I never had surgery. I never had any issues with broken bones. So my expenses, if I were in poor health, would have been $700. But I was probably closer to these people over here on the left-hand side, where I was virtually spending almost nothing every year. And so this is what I wanted to share with you tonight. because we, now we've just to go back and recap some of these charts that we looked at before. Here's the level of spending from 2000, or from 1980 to 2015, moving from like I don't know, a little over $2,000 up to over almost 11,000 something. And we saw that was spread out across this grouping here in age category. But, some of these heavier expenses driving this up were actually found in some of these lower age groups. That's something we discussed. So that was one of the things we covered first. And I'm just going to try to bring you to a point where some of this is tying together. And then on the second category, healthcare spending is almost twice as high against these other countries. And this is what I was saying earlier about the mammograms. See, as a government, the government spending on healthcare is basically equitable. Nearly all of these others have a segment of privatization about them, but it's so much less than ours. And our government spending actually is right in the middle, or does better than a lot of other countries. And we're probably right equitable with Canada with that, and better than France and Germany and Japan, for example. What cost us, what sends us soaring over everybody else, is this private cost. That cost I was just talking about, where that diagnostic mammogram, $800, $900, $1,200 for every female over 40 who might have a problem. That's quite an expense, and the cost of that could vary in so many different places. So we saw that as we went through some of this, and then we saw that most healthcare spending is on hospitals. And again, this is the part that I want to reemphasize. It ties together. Here's your hospitalization, your hospital care, and things that are actually done in the hospital count for about 33% of the expenses associated with healthcare. Professional services like your doctors, like your dentists, like your eye orthodontics, your eye doctor, and other people. And if you look down here, prescription drugs only count about 9% of that overall cost. So we're spending a lot of time worrying about this in terms of the overall healthcare system. It's not doing much. This is where we have a problem. And the things that you saw tonight that I discussed at first are the things that are causing that problem the most. So that's part of it. Then last Wednesday we talked about 5% of Americans accounted for half of all of the healthcare expenses in the country. And that chart was really interesting because you broke it down here from 99 to the 100th percentile, then the 90th percentile, and you can see these coordinating and correlating with these here, and how much people are spending annually on these kinds of expenses. And it gets down here to the bottom percentile, and you get down to virtually only 3% of the expenses. So when you look at bills like this mounting up for people or in this area here, yeah, you see that top 5% accounts for the large chunk of our expenses in healthcare. And then you go back and look at what we just covered, and you see that's happening in hospitalizations and professional services for the most part, not long-term care. So it's not about the aged, it's about health, and which brings us to this point. It's about this grouping here who are spending a lot of money on ongoing basis and privatized insurance. So a lot of these people, a lot of this expense on the Medicare side, is, as we saw in that government comparison, is very well managed. A lot of these expenses driving this up high are the privatized, the supplemental programs of the private insurance people who haven't turned 65 yet, but are in extremely poor health, and they're paying out of pocket for this. They're paying out of pocket for this, or insurance companies are paying a large portion of it. So you can see why something like this mammogram story really is a problem. It really points out some of the things that are going on out, and that's just one of them. This is one of them. Just try to discover how your insurance is being billed to you. Try to determine what the charges are. Why do you get charged this much for this? Is it comparable from somewhere else? If you ask us questions, first of all, if you try to find them, you will not find them in the literature. They work really hard to keep that information out. You have to find studies that are criticizing it in order to be able to know the real information out there, because they won't tell you. I mean, I called for lots and lots of people. I got stonewalled in more ways that you can imagine, and you can't work your way up to the top, because if you express to them why you want to talk to the person at the top, they're not available. They're just not available. Insurance people and folks. I even asked doctors, and some doctors really just, they don't buck the system. They don't buck the system, because if they do, their livelihoods are at stake. It's kind of like they're trapped inside of this circle that they can't get out of. They can't do anything to get out of that circle, and that actually affects how they relate to you as a patient. I don't know if you've seen it. I didn't realize it, because maybe I just never experienced it. I never went to a doctor that much. But a lot of people I've talked to lately have told me, over the years, have noticed, doctors becoming more distant, and they join clinics as opposed to having a private office, and their hours are becoming much more restricted, and then they use hospital services as opposed to sending you to a lab that they may trust or use, that is independent from the hospital, maybe not cost you as much. So these are the things that are impacting us. These are the things that are going on right now. So that's part of where we're going down the road. So there's more to come about how these operate, and I'm going to find a period of time to discuss. Let's see, I think I have it over here. I don't know if you'll be able to read this or not, if it comes across backwards or not. It does look like it might come across okay. I'll check here as my Facebook catches up with me over here on my iPad. Yeah, in medical debt. Here it is right here. I'm going to put this in my Facebook page and on one of these videos, probably coming up the next week. And these guys used to be bill collectors, and they've gone into a private nonprofit organization to collect money to pay bills off for people, and they're doing a great job of it. But they cover in this book, let me just give you just a few things out of it. Medical debt is the enemy of everyone. Okay. Debt mountains cause healthcare deserts. These are chapters in the book. Seeing Through the Tears talks about really understanding what our healthcare system is doing to people. People who can't control it. They don't have any control over it. It's not their fault. There's one in here called John Oliver effect. We won't discuss that one. Debt is in the details. Fanciful healthcare financing, believe that or not, that's kind of interesting. You're going to find out a lot of healthcare hospitals are in it as conglomerates to satisfy stockholders. Uh, Health is a goal, not an industry, which is something's there. And, there's areas in here like, our hospitals thinking with their heart, or are they thinking with their head? That was a good segment. And it talks about doctors' relationship with hospitals and how people are kind of pulling together, and how our healthcare system is so discombobulated from that standpoint. So as I run into these examples, I'm going to try to present them to you as part of these segments. So they may run a little longer. But I think they're important to kind of emphasize, because this one today on mammograms hit on so many. It hit on people who are not in the poorest of health, that are trying to stay healthy, preventative, and it hit on how hospitals are taking advantage of that to generate revenues. How the confusion of just using semantics, the difference between screening and diagnostics, to take the cost to you from zero to maybe $1,000 or more for that mammogram test, and which may not be covered under your private plan. Now, under Medicare, the diagnostics, after you meet your deductible, which I think is like $375 or $400 somewhere in there, after that, you would only be accountable for that plan. You'd only be accountable for about 20% of that cost of that second diagnostic test. That's under Medicare, though. That's not under your private insurance. If you want that on the private insurance, you got to pay a little more every month for it. So, it just irks me, because I see, hey, if I were a woman, I was on Medicare, I'd be far better off than somebody that's on a private Medicare plan who starts at 40. And to have something like breast density to be the criteria for the differences of this is kind of absolutely ridiculous. So anyway, more to come on our healthcare system. You're going to find out. You may want to think about what you really. This is a year where there may be an option to select the absolutely best possible healthcare plan we could have for everybody. Now, by the way, in Canada, I looked up Canada. In Canada, these are basically pretty much covered. The diagnostic may be like our Medicare plan, where it's you pay a very low percentage or something like that. I'd have to go back and look at their plan specifically. But generally speaking, most of the people are not worried about it, but they are very concerned about making sure that their definition of it is well written to encompass everybody being able to get the preventive care they need, because they know in the end that's going to cost the government less money for their health care plan. And it appears, from people I've talked to, and I live not too far from Canada, so I've met a lot of people from Canada here. They don't seem to have a problem with the healthcare. I mean, a lot of people like to shoot it out there. You can't get your doctor. Waiting lines are forever. I don't hear that from anybody. It's from Canada anyway. I hear it from some people in the United States who don't want a Medicare for all because it's socialist. I hear it from them, but I don't hear it from the people. And in Europe, I didn't. When I traveled in Europe consulting, I didn't hear it over there. I didn't hear people complaining about it. Plenty of opportunity, because I worked on those programs for a company that was international over there building those kinds of benefits programs up to kind of so that the U.S. company operating in that area could be competitive for hiring. So anyway, you have a great day. Once again, if you don't mask up, folks, if you don't mask up, if you don't social distance, if you don't give up this Thanksgiving, if you haven't been around the people you're going to visit, you could be setting them up to get COVID, and if it's someone like me, you could set them up to kill them with that COVID. And that's not going to be a good feeling if you leave that party because you felt like you just needed to do it. Then you're not thinking of them, you're thinking of yourself. Then you're going to end up living with that. And we see on the news now people saying that over and over and over again. Just tonight, I saw on CBSN in, I think it was Wisconsin, a guy was, one of the anchors was, or I mean, one of the reporters was catching people going into a bar. He caught two girls and they were talking. They said, yeah, we're not big about having to wear a mask and all that. And one of them she admitted right there on camera that she was a COVID nurse. And when David asked her, you see this every day. How can you? And she says, I know. And so that's the power of this COVID, I don't know, COVID effect is having on people where, you just don't want to stay inside in one minute more. This is a lady, had she gone in that bar, instead of going in to work tomorrow, she needs a quarantine for 14 days before she could report to work. But she wouldn't have told them that. She wouldn't have told them that. Pretty sure she wouldn't have told them that. Pretty sure she might have been doing it all along. So there you go, folks. Not only did she risk herself, look at how many people in that bar she might have been putting at risk. That's pretty phenomenal stuff. So wear your mask, stay socially distanced, hang on for another 3 months. It's only about 3 months before those vaccines start really popping out there. Please do that. All right, this is Vic Vogel. This is What the Flip. And we'll see you Wednesday night, 7 p.m. Oh, I'll be here tomorrow night at 7 or at 9:30 p.m. Tomorrow night, 9:30 p.m. Just talking about how you getting along, seniors, how you coping with things. And we'll talk about whatever pops up, between now and then, just to discuss how seniors are dealing with COVID, what's going on here. I know things like I heard tonight really just make me mad. They make me mad. They get me really upset that people are that selfish, that they would not care for the people. That says we're going in the wrong direction, not just as a country, but as a human race. My God. All right. Have a good day. Mask up, and I'll see you tomorrow night if you join me for senior. If not, if you're into this series, I'll see you Wednesday night with fact number 6. Have a good evening.